Well, good morning. I'm actually in Phoenix, Arizona at the Desert Foot meeting, and I'm sorry I cannot be with you on the day of your meeting to give this live. But it's a great honor for me to be invited to give this lecture and to be with, at least virtually, many friends and colleagues from across the world. Now, you know the title of my talk, and this is really my lifetime history. A 45-year-old journey. Actually, I'm older than 45, by the way. A 45-year-old journey from leprosy to smart technology in the diabetic foot. But I'm going to go back to Nottingham in my school days, where I went to Nottingham High School. My whole family was in English literature. I was a sort of dropout. My father was professor of English at Nottingham, where D.H. Lawrence had also been to the same school. And he was from Nottingham, and he was the famous author of books such as Women in Love, Sons and Lovers, and the famous Lady Chatterley's Lover. Now, he had been to the same school, Nottingham High School. But it was actually another Lawrence that I got to know better, not in person because he died back in 1968, but he was one of the first people in England to receive insulin. He was training to be a surgeon at King's College Hospital back in 1922, and he developed thirst and polyuria and knew he had type 1 diabetes. And in those pre-insulin days, that was really a death certificate. So he thought, oh, I'm going to go to somewhere nice. I've got a year or two to live. And he went on the famous Allen diet, lost a lot of weight, and went to work as a general practitioner in Florence in Italy, which I'm sure you will agree, especially our Italian friends there, is actually a very beautiful city. And he was working there and had all sorts of problems when he was very high blood sugars because of lack of insulin, of course, including painful neuropathy, which I'll return to. When he got a telegram in 1923, come back quickly to London. We have this new drug called insulin. It seems to work. And he wrote in his diary, this is probably quackery. But he went back anyway and became the first person to be one of the first to be treated with insulin successfully in the UK, and changed his mind from being a surgeon, very wisely, of course, and became a diabetologist and was the senior diabetologist at King's College Hospital in London for many years and lived until 1968. And I actually gave the R.D. Lawrence lecture many years ago, 1990. So back to my life history. After Nottingham, I went to medical school in Newcastle upon Tyne in the northeast of England. And it was well known for neurology. And I became very interested in neurology in many ways due to the excellent senior professor of neurology, Professor Boulton, later Sir John Boulton, and lastly, Lord Boulton, for the years until he died. He's in his 90s, just a few years ago. He was warden of an Oxford college, but he was an excellent neurologist, a great clinician who focused really on clinical science and examination and the importance of taking a good history. And every week, he would have a seminar in a large room, and he would bring in a patient who he had been asked to see with a difficult case. And it was full of medical students, junior doctors, senior doctors, and even his consultant colleagues who would attend this session. And Walton would be presented this case that we hadn't seen before, and he would take a history, an examination, and then would come to the diagnosis, which was invariably correct. Now, on this occasion, the patient, who was often international, had only come locally from County Durham, just to the south of Newcastle. And also during this presentation, everybody was sitting listening very carefully because he would pick on people from the audience and ask them to do history or a brief exam. And the more senior you were, the more difficult this got. Well, the first person he called upon that day to examine something on this patient was me. He said, Boulton, I want you to examine this patient's fundi, and gave me an ophthalmoscope. So I did indeed look in the fundi, and this is what I saw. And this, of course, is optic atrophy. I said, as you would in those days, not like medical students today, but I said, sir, this patient has optic neuropathy. Well, he said, yes, he does have optic neuropathy, but Boulton, you looked, but you didn't see everything. Medical students, you see, told me need to look and see. Now, you had some difficulty examining the fundi. Why is that? Because you missed the fact he has a pendular nystagmus, which is equal phases of the eyes moving across. So nystagmus is the flicking movement of the eye. And he deliberately left his shirt open so you could see his chest. You didn't notice that on his chest he had what we call coal tattoos. And these were black marks in skin creases that were really very common in miners who were coal miners working underground. And he said, well, if you'd have seen everything, you got the most important thing, he had optic atrophy, but you missed that he had nystagmus. And the clue came because if he had nystagmus and you look at the chest, he's got coal tar, whatever they call them, tattoos, coal tattoos. He said, this chap must have been working for many years as a miner, working as a miner underground, and miners in those days started in their teens. He was in a very dim lighting for most of the day. So he couldn't focus, hence the pendular nystagmus. So I was very impressed by this. And of course, the case went on. And I'm pleased to say that other people made serious errors as well. I don't think my error was too serious, but I learned a lot from that. Well, then I moved to Sheffield after my intern jobs, or house jobs as we used to call them, and worked in Sheffield and was doing a registrarship in neurology, first of all at the Royal Infirmary, which is now an old people's home, and then the Hallamshire Hospital. But I came across as a registrar Professor John Ward, who many of you will remember died just before the pandemic. And he was very interested in diabetes complications, particularly neuropathy. And what he emphasized was learn by observing, again, just like Boulton, good history and exam. And he said, do not try to do too many studies, identify one or two research questions. And he said that clinical research grows out of being a busy clinician. And of course, he was right. So back to R.D. Lawrence, as I said to you, he was one of the first people to receive insulin. And I gave the R.D. Lawrence lectures, as I said. But before that, I read his notes. And I was most interested that when he was in Florence with terribly high blood sugars, fluctuating from high to very high, he wrote this: I don't like peripheral neuritis. It interferes with my work. It's uncomfortable. So that led me to think perhaps that the pain of neuropathy is something to do with very high blood sugars or fluctuating blood sugars. And that's his quote there, 1923, I don't like peripheral neuritis. It interferes with work. So in my early days in Sheffield as a research registrar, I was contemplating what causes neuropathic pain. And the most interesting here is neuroma properties. So we know that diabetic neuropathy is a dying back neuropathy. The nerves die back, so the longest nerves are affected, such as in the feet and legs. But there's also attempts at regeneration. And regenerating nerve fibers fire messages, ectopic impulse generation. And these messages in C and A delta fibers are pain interpreted as most uncomfortable pain that reflected often in the area where that nerve used to supply. So what causes neuropathic pain? So it's probably this, plus perhaps glycemic flux, blood glucose swinging from high to low. So one of my earliest published studies in 1982 was we looked at a number of patients with painful neuropathy and put them onto very early continuous subcutaneous insulin infusion, not the modern stuff today with CGM, closed loop, etc. This was using a syringe driver with a subcutaneous connection. And we were able to look at 4 months of near normoglycemia, continuous subcutaneous insulin infusion. In those days, it was not Nova Rapid, whatever it was called before that. I can't remember. So something like Nova Rapid, but not a human. And 4 months of near normal glycemia, the pain score actually fell from 7 which is the graphic rating scale maximum 10 to 2. And this is associated with, as best we could measure it, with regular glucose finger prick tests from a baseline of 85, that's very high fluctuation, down to 26. So we thought that stable normoglycemia might be important in the genesis of neuropathic pain. So 20 years later in Manchester, I was able to actually confirm this in a study we published in Diabetic Medicine in 2002, because at that time they'd just started the rather old-fashioned now continuous glucose monitors, the Medtronic one. And so we were able to look at glucose excursions in painful and painless neuropathy. So we took type 1 diabetic patients with, all of them had a dense peripheral neuropathy, but half had pain and the other half were painless. And we wore the Minimed, now Medtronic. They wore the continuous glucose sensor for 3 days. And those with painful symptoms kept a regular visual analog scale of their pain. And we were able to measure, like we did in the first study, fluctuations from the mean. Now, that's the old-fashioned Minimed. And today we have the very fancy, for example, the Libras, Freestyle Libra on the upper arm, but this was much more complicated, of course. But it still did continuous glucose tissue monitoring, and we were able to measure very regular tissue blood glucose or tissue glucose levels. And this is a profile of someone with painless neuropathy, no symptoms at all. And you see the overall control is not brilliant. 10 is 180 milligrams percent if you're used to that, and 5 is 90. These are the blood glucose, capillary blood glucose, which really correlate brilliantly with the continuous tissue measurements here. But you see here, this is relatively stable control. What we saw in those with painful neuropathy was this kind of profile all over the place, overall control worse, and again, higher levels and more fluctuation. And the results of this study were that in the painful group, the overall control was worse in millimoles. This is, that's around the average was just over 200 milligrams percent. Many more hyperglycemic values compared with the painless group. And the M value, which is a special measure of excursion from the mean, was twice as high in those with painful as those with painless. And the median numbers of glycemic excursions of more than 0.5 or 9 milligrams percent was again higher. So we felt that patients with painful symptoms have poorer diabetes control, higher mean blood glucose readings, and greater blood glucose flux. Well, back in 1983, I went as a young visiting assistant professor to the University of Miami for 2 years, working with my good friend, Jay Schuyler, who many of you will know. And the importance of history and examination came home again. Because in 1983, I was doing one of my clinics when this interesting patient came in. Eventually, we wrote him up in the British Medical Journal in 1984. And this is entitled Diabetic Thoracic Polyradiculopathy Presenting as an Abdominal Swelling, as you can see here. Now, this guy's history was that he had been to his primary care physician in North. And he said, I've woken up with this strange bulge in my side. And the GP looked at him and he said, yes, you have got a bulge in your side. So thought it might be a hernia, sent him to a surgeon. And the surgeon looked at him and very carefully said, I don't know what this is. I don't think it is a hernia, but I'll get you into hospital for a few days and we'll do a few tests. So he had barium studies at both ends, as you did in those days, 40 years ago. Some primitive scans that were available in those days. And the surgeon said, I can't find the cause. So he sent him then to a gastroenterologist, then to a urologist. So he had intravenous pyelogram, as it was then called as well. So he had all these tests. And then the surgeon said, oh, look, this guy's got diabetes. Perhaps we'll ask someone with diabetes to see him. So he was sent to see me. I mean, he wasn't done well. He didn't really need to be in hospital. So he came as a new patient to me in my outpatient clinic in Miami in 1983. So I sat down and actually took a history. And I said to him, okay, you say you woke up with a bulge in your side, which I can see, but just tell me, did you have any strange feeling or symptoms in any part of your body? Because I know you have diabetes, and you had no neuropathic symptoms in the past. He said, yes, actually, the night before I woke up with this, I couldn't sleep very well because it was a very strange pain in that area too, especially if I sort of turned over or brushed my skin against the bedclothes. So the penny dropped then. So I thought to him, okay, that sounds like a neuropathic pain. And can you describe it? He said, very difficult to describe. It's sort of like a burning, or the skin was on fire. Always very difficult to describe neuropathic symptoms. So then I examined him, and he had absent abdominal reflex in the lower part of the abdomen here, and hyperesthesia and allodynia in this region here, in the sort of T6, 7, 8, 9 region. So I thought this is a thoracic polyradicular neuropathy that actually presented as an abdominal swelling rather than the usual neuropathic pain in the abdominal wall. So one test I did, it had thousands of dollars of tests, and heaven knows how it cost even in those days to stay in hospital for a few days. One test, an EMG, and this gave the diagnosis. He had fibrillations and abnormalities in the thoracic muscles in these dermatomes, or this area, sort of T6 to T10. And the diagnosis was a diabetic thoracic polyradicular neuropathy. I can hardly pronounce it myself. It's because of the dry climate here in Phoenix, I think. So he had this thoracic polyradicular neuropathy, and I gave him some simple painkillers, and I said, look, this should get better within 6 months. So 6 months later, he came back to me. He said, Doc, you're brilliant. The pain's gone and the swelling's gone. I said, I'm not brilliant at all. I didn't do anything for you. Just gave you some aspirin. I said, this is the natural history of the condition, and there's no specific treatment, and it got better. So that was very important. Taking a history and a good clinical examination could have saved the healthcare system there many thousands of dollars, which, of course, next week, I'm pre-recording this just before the election. Heaven knows who'll be in power, but it all depends who is, how much it costs. So whilst in Miami, I'd previously been interested in necrobiosis, which I saw quite a lot in Sheffield with John Ward. I noticed that it occurred generally in young type 1 diabetic females, not in type 2, as the literature suggested, but in type 1, who had other complications. And we also noticed there was reduced sensation in the lesions. So it was well known to be a rare dermatologic complication of diabetes with a prevalence of 0.3%, 10 times more common in women. And the old literature said, and this is a big study here many years ago, also occurs in non-diabetic individuals, but if you really press them, you can find an abnormal GTT. Well, I thought, let's do a study while we're in Miami, because there's a very good dermatology division. They were interested in this as well. And this is what necrobiosis looks like here. These sort of very, usually painless, but it can be painful at times. They can ulcerate. And this is a healing ulcer here. And you can see all these telangiectasia and this sunken with a raised edge. This is the classic and a sort of yellowish, lipid-like looking view, or what it looked like anyway. So you can see this slight concavity here. Here's a better example. You can see this concavity here, and this is the same patient with a different view. So this is necrobiosis lipoidica diabeticorum. So as we were seeing it frequently, as we had a large population of type 1 diabetic patients, and we saw 15 cases and 10 previously, so 25 patients in this study. And we published this necrobiosis lipoidica, a clinico-pathologic study, and this was published in the Journal of the American Academy of Dermatology in 1988. And it's probably the first and the last paper, I have to say, I'll ever publish in that journal. So what we did was, many of these did have ulcers. Here's an ulcerative case, as you see here. So what we did was, why don't we look at some biopsies, of course, with IRB permission, biopsies and look at what's going on here and the explanation to see why there's reduced sensation. And what we showed here, here's the biopsy across, this is the lesion here, and this is the perinormal skin. And you can see the first thing here, here's the lesion. In the perinormal skin, there's gross inflammation with necrobiotic fronds of tissue here. So it appears that the necrobiosis actually moves underneath the perinormal skin, which has an important message for if you're going to give intralesional steroids, they're probably best given around the edge. But the second thing we found when we did S100, let's go back one, S100 protein, which is a cutaneous nerve identifier. And this is a normal skin biopsy here. And this brownish discoloration, especially here, is S100 protein. So these are cutaneous nerves. But in an active lesion of necrobiosis, this had changed. There's hardly any staining for S100 protein. So we thought, what's happening here is the necrobiotic inflammatory tissue is destroying superficial nerves, which explains the loss of sensation in the lesion. So this could be a very good sign for necrobiosis. It could be pathognomonic if you can't decide if it's necrobiosis or not. Is the loss of feeling in the lesion? So this is the summary slide here. It's most commonly seen in type 1. Most of these patients had other microvascular complications. Necrobiotic fronds are most active under the perilesional skin, and that necrobiotic tissue destroys superficial nerves, and this loss of sensation in the lesion can be pathognomonic of the condition. So that was the importance of clinical history and clinical examination. And then came my first visit to India, where I spoke at a congress with the Indian Congress. I can't remember what the building was called, but it was a research area in a beautiful park in the south of Madras, now Chennai. Here it is, the proceedings to the International Conference on Biomechanics and Clinical Kinesiology of Hand and Foot in Diabetes and Leprosy. And this was in the Indian Institute of Technology, which was in that nice park. Most important of that whole meeting was that I met Dr. Paul Brand. Now, many of you have heard of him. Some of you may have known him, but it was a great honor that I knew him from 1985 until he died 8 years later. This is a very historic picture taken at one of Larry Harkness's meetings in San Antonio, probably in the late 1980s. And this is Wagner, and that's not the composer. That's Wagner, F.W. Wagner, who described, along with Meggitt, the classification system, the first one in the University of Rancho Los Amigos, Los Angeles. Well, that's F.W. Wagner. And this is the late Roger Pecoraro, who sadly died very young and worked, of course, with Dale Reiber, the epidemiologist, and has a prize of the ADA named after him each year. This is Lee Sanders. He was the first podiatrist ever to be president of American Diabetes Association. Many of you will know Larry Harkness, a great character and sort of father of podiatry in America. And here's Dr. Paul Brand, and I'll say more about him. And by the way, the person on the left here is actually me nearly 40 years ago. It shows you the dangers of working in the diabetic foot. Probably a good thing you can't see me today, by the way. And he had worked in Vellore, the CMC in Vellore, and in Karigiri, where he worked. And this is pictures from South Tamil Nadu, the beautiful grounds of this hospital in Karigiri. And of course, we saw terrible sights when I first visited there. Young people with loss of limb, intractable ulcers, scarring, deformity. And this is people with leprosy, of course. And the typical view, this is a few years later when I visited, just driving from Madras down to Vellore, the typical oxen cart. And these people are all walking barefoot. And when I saw people walking barefoot, and some of them had a foot drop, they almost certainly had leprosy. So what did Dr. Paul Brand tell us? Well, he told us a lot. First of all, as did Sir John Walton, my mentor, the importance of clinical observation. And he rightly stated that any patient with a plantar ulcer who walks into the clinic without a limp must have neuropathy. And that's true. Very important clinical sign. And he described as pain as God's greatest gift to mankind, which you only realize is a gift when you lose that gift, and leads to all the problems we see in diabetic patients with foot problems and, of course, leprosy. This is a leprosy patient in Madras I spoke to many years ago, and he cited this patient. I shall never be free until I can feel pain, as he came back with a recurrent ulcer. Then he moved to the rather splendid area on the grounds on the banks of the Mississippi River in South Louisiana, known as Carville. Carville was the National Hansen's Disease Center in the United States. And I had the pleasure of lecturing on some courses. Dr. Brand worked there. A very splendid place. And anybody with leprosy until the late 1960s were moved there and given a house, and they spent the rest of their lives there. So it's a very interesting place to actually visit, to lecture, and speak to people with leprosy. And Brand said to me, when I started seeing diabetic ulcers, it reminded me of leprosy ulcers. He said, these are not diabetic or leprosy ulcers, these are trophic ulcers. And of course, he was right again. And he said, in diabetes and leprosy, it is not the disease itself, but neural damage caused by it that results in ulcers. Well, I moved in 1986 as a consultant to Manchester Royal Infirmary, which didn't quite look like this then. This is an older picture, and today it's looking a bit different. I'm not sure which one I prefer, by the way. The older one was a very handsome building, which I was working in until they demolished it and built this thing. And one of my first fellows was Aristides Vevis, who's now a professor at Harvard. And Paul Brand said to me, I'm sure that it was loss of feeling, but he was very keen that I did a study, as we spoke a lot, to look at what caused neuropathy and prove it was neuropathy. So we did an observational prospective study soon after I came to Manchester, started back in 1988. We measured vibration perception to assess neuropathy, and we recorded all foot ulcers. Using the biesthesiometer, many of you will be familiar with this, and the reading is from 0 to 50. The higher the reading, then the more significant the loss of vibration perception, large fiber function. And what we showed here, the total number of ulcers, if you just look at this line here, the risk per patient per year, those with no basic neuropathy, BPT less than 15, 0.7%, less than 1% risk. And these are first ulcers. None of these patients had a history of ulcers. But if your BPT was more than 25, it was sevenfold and increased up to 1 in 20 or 5%. So then, you know, we think about temperature monitoring and all the smart technology we use today, but most of it was described by Paul Brand, pressure relief. He did some very early foot pressure measurements and looked at the contribution of footwear to ulcers, and he had a very early development of pressure sensing devices to warn of high pressures. So he had some very primitive sensors and showed that pressures were high under the high pressure tarsal heads of the diabetic foot, and published this 60 years ago. So we were able to take this further with a sophisticated, in 1980s, firstly in Sheffield, then in Manchester, a sophisticated machine, or optical Peter barograph, and we were able to demonstrate, working with Matthew Young and Aris Bevis, that high foot pressures are associated with first and recurrent ulcers, and that high foot pressures predict ulcers in the neuropathic foot. This is a series of publications from these studies, first in Sheffield and later in Manchester. Well then, to take a slight aside, I was associate editor of diabetic medicine with Philip Home, some of you may know, and I got a call one evening at home, and this is the first issue here in 1984, So this was, I got a call, I think it was about 1990 at home, and it was Sir John Nabarro on the phone, who was then chairman of Diabetes UK, or British Diabetes Association, as it then was. And he said, "Is that you, Boulton?" I said, "Yes." "Sir John Nabarro here." He said, "Philip Holmes said you've been very helpful with diabetic medicine as the senior associate editor. So we'd like you to be the next editor. So don't rush, think about it. I'll call you back in half an hour." And indeed, he did call me back in half an hour. So I took on this and was that for the next few years. And then at the end of that time, Professor Michael Berger in Dusseldorf, who's another very strong character. Some of you may have heard of him. He tragically died young of a retroperitoneal tumor. But he was really a very decisive person. And when I was finishing my editorship of Diabetic Medicine, 1994, he said, "Andrew said, we'd love you to be the next chair of postgraduate education on the Executive Committee of European Association for the Study of Diabetes." So I took that job on, and I was worked at that one for 6 years as chair of PG, postgraduate education for EASD. And we hosted a number of courses. First of all, my first job was to really take educational courses on basically diagnosis, prevention, and management of diabetes and its complications, bringing experts from all over Europe. Firstly, I was responsible mainly for the former Warsaw Pact and Soviet countries in Europe, and we did courses all over that region. But after that, I was asked to take on the new task of the international education. We did courses all over the world. This is one of the first courses we did in Kaunas in Lithuania, because my wife and colleague, Professor Loretta Vilikite, is originally from there. So having those connections was very important. The first course we did there was actually before 2005. This is one of the later ones. And we have a number of well-known people lecturing at this meeting, including there's Ben Lipsky, David Armstrong somewhere on the picture, Roy Freeman, and people from all over the world. And there's Lee Sanders again, you see there, and David Sachs from National Institutes of Health. And we had local speakers, and we put on postgraduate education, not only for Lithuania, but for the Baltic countries as a whole. And we brought people in from other neighboring countries, such as Poland, and in those days, White Russia or Belarus. One of the early postgraduate courses we did internationally was in Panama. We had a very large turnout here, and again, we brought in well-known international speakers. Here's a later one in Vietnam, which was an interesting one in 2008, and later in China, and there's one in 10 years ago in Baku in Azerbaijan. So I became president of EASD, and during my presidency, EASD celebrated 50 years of progress from its founding in 1965. And the EASD has come a long way. And of course, we were so lucky to be able to put on one of the first important cardiovascular endpoint studies for the drugs that had to be done by FDA rule. And this was the EMPA-REG Symposium. One of my last tasks as president in 2015 was to introduce this symposium in Stockholm at the EASD meeting, that 50th year anniversary. And this had a huge audience. And it's the first time I've ever heard of spontaneous clapping during a presentation, which is what occurred. Of course, since then, we've had many more interesting studies with GLP-1s as well, and also the SGLT2 inhibitors. That was the team in Dusseldorf that ran the EASD in my last year of presidency. And there's Victor Jorgens, who many of you will remember, who was the executive director. Returning to India, I was fortunate a few years ago, or more than 10 years ago, I think, to share the stage with Sri Narendra Modi, the Prime Minister of India. And this was a most interesting meeting. And in his speech, he said the biggest threat to our survival in India is no longer infectious diseases like leprosy, malaria, tuberculosis, HIV. It's non-communicable diseases like diabetes. So I said to him at the end, "You're quite correct, sir, on that one." And I think they're taking diabetes very seriously, and his government is. But I also became involved in South America, and I'm jumping around the world a bit now. And this is, of course, South America, and the biggest country is Brazil. And in Brazil, I was involved with Linda Pedrosa, who you all know, a very good friend, and she did some training with me in the early 1990s. I flew out to Brazil to help implement the diabetic foot clinics across Brazil. This is the first one in the capital, Brasilia. And then here we are to 2001, 34, another 10 in actually implementation. And then by 2007, there's a large number of foot clinics. So this was a very enjoyable and productive collaboration in helping to secure good foot care in India. And of course, the step-by-step programs, which my good friend Abbas and Vijay and all the people who are listening today know very much more about than I do, have become so important in that region. I know Linda has been a leader in the South American region. It's difficult to give exact data from the effect of starting these clinics, but this is just looking at the Brasilia Center here. And from starting the foot clinic, you can see the actual females and males, a generalized trend to reduction of major amputation over the 8 years since it started. Then I was involved in Asia. I told you about Vietnam. But our very good friend Shigeo Kono from Kyoto, and this is a famous temple here in Kyoto. He did so much work in the Western Pacific region of IDF, International Diabetes Federation, and these are some of the foot ulcers he saw on his travels around countries, which are major problems in countries, especially I think just Cambodia and places like that. And he would run a course every year. It would bring diabetologists and expertise and neurologists and infectious diseases. One of these has Ben Lipsky on it, and these continued for many years and have just finished because I think Shigeo has actually taken retirement now. I'm sure he's still active. So this is activity in that region. And then lastly, of course, we mustn't forget, for many reasons, sub-Saharan Africa. Looking at the IDF Atlas, and I was president of International Diabetes Federation until the end of 2021, from 2019. So it was a 3-year I did. And what happened here is that the biggest, we put an atlas out, as you know, the last one was 2021. Actually, I think I finished in 2022. That was the extra year I did because of the pandemic. So what is happening in the world is that the biggest increase in the prevalence of diabetes in the next decade is likely to be seen in sub-Saharan Africa. So this is such an important area. And of course, Abbas led an article that I was on looking at diabetic foot problems published in FRCP a couple of 2 or 3 years ago on foot problems in sub-Saharan Africa. And it was a pleasure to be there. Again, this is 10 years ago. There's my good friend Abbas who's introduced this meeting today with myself. And I think this was the Minister of Health talking about the importance of diabetic foot problems and the Pan-African Diabetic Foot Study Group, which was then being founded by Abbas and others. So coming back to the last section, what's happening in terms of new technology? And of course, what we're seeing now is smart technologies being involved in diabetic foot ulcer prevention. Thermography, again, it was Brand 50 years ago who said that the diabetic foot warms up before it breaks down. And of course, he was right. And continuous plantar pressure monitoring, 60 years ago, Brand had talked about the importance of pressure. So we now have smart technology, and this is a smart thermographic bath mat, if you like, and the patient stands on this, and it's read centrally And this is one of my good friend Bob Freiberg's paper. And again, you can have continuous plantar pressure monitoring and have a picture here of Bijan Najafi, one of his studies. So it's see it, save it. Simple things can help. This is the pressure stat, which is a more advanced type of Harris mat. Now, the Harris mat was used, of course, a lot in India and leprosy, but you tend to get a lot of ink on your fingers. This is much cleaner, and you can give this to the patient, and it just shows the pattern of high pressures. The darker the area, the higher the pressure. The patient can pin this on their bathroom wall to remind them this is the area they should look at each day. So seeing is believing. This is one of the other, excuse me, I've been giving too many lectures here, I can tell. It's early morning. So this is the temp stat, which is can measure temperatures just by standing on it. And a more modern version actually can directly give the patient a picture of their own foot. And we have smart socks as well. And this is Siren Healthcare won the success at the Consumer Electronics Show. They won the prize for the most innovative development. And these were smart socks that can measure pressure and temperature, run by Dr. Rand Marr, who used to work with David Armstrong. And this here, it shows from Siren Care, obviously a high-risk foot. Medical students will look at this and miss that there's a toe missing, but I think you all can see that. And here you can measure the temperature, and if it gets warmer and stays warm, then you can do something about it. So, of course, Bob Freiberg did one of the early studies with the Podometrics device, and this was 132 patients he followed for 34 weeks, published in Diabetes Care 7 years ago. And daily foot pressures were measured remotely, but they weren't fed back to the patient because this was just an observational study to see if high temperatures predicted foot ulcers. Well, these were high-risk patients with a past history. Plantar temperature asymmetries were analyzed, and over 1 in 4 had foot ulcer episodes, and nearly 100% of these were correctly predicted using a 2.2 degrees continued asymmetry for a day or two between the active foot and the other foot. So now ongoing studies, of course, are happening, randomized controlled trials. Here's a study I was involved in, my good friend and collaborator, Professor Neil Reeves, and Caroline Abbott, who's worked with me for many years, you probably know. And this is a novel plantar pressure sensing smart insoles, not temperature, this is pressure. You can wear during normal gait, and it can help warn you if there's a problem. So we know high foot pressures contributed to foot ulcers, where pressure is a laboratory measure, but can we give pressure feedback using smart insoles? And we can. And this were put inside the shoe, and the patient had a wristwatch that didn't actually tell the time, but would vibrate if one foot was high pressure, abnormally high, or both feet pressure. You look at the wristwatch, it would tell you which area was too high, and the patient could either alter their gait or rest, stop walking until it was settled. Well, the results were quite convincing. The recurrent ulcer rate was reduced by 71%. This is, of course, pressure offloading plus patient empowerment. Most important, the patient had something they could interact with, and if they told them that something was wrong, they could act on that themselves. So, to finish with COVID, mortality in those with COVID-19, as you all know, was much more common in people with diabetes. They were older, male, poor glycemic control, hypertension, and cardiovascular disease. But look, isn't this the same as risk for foot ulcers? Older, male, poor glycemic control, hypertension, and other diabetes complications. So COVID pandemic was a nightmare for diabetes because of people dying in my hospital. I think it was 1 in 3 or 1 in 4 had diabetes. So what happened? At the first lockdown in March 2021, my hospital suspended all routine lab tests unless there were actual acute emergencies, suspension of all routine investigations, including x-rays and MRIs, other than an emergency. and non-invasive vascular tests unless an emergency. So we were back to the sort of 1960s. But I kept my clinics going, and I moved all patients with foot problems from the hospital to an off-site clinic because patients were frightened to come to the hospital. People knew that people with COVID were likely to be in the hospital, and diabetes plus COVID is bad. And if I go to the hospital, I've got greater risk. We published this paper, A Tale of Two Cities, Saving the Diabetic Foot During COVID, with my former PhD student, David Armstrong, as you all know him, and his colleague, Laura Shin, and Frank Bowling, and myself in Manchester. We had compared two diabetic foot services. A Tale of Two Cities was not the Dickensian Paris and London, but it was slightly different, Manchester and Los Angeles. And we looked at the caseload compared 6 weeks pre and post weeks lockdown, changes in care and outcomes. And we saw huge changes. Pre-lockdown, we were seeing 373 patients a week at our diabetic foot clinics. Post-lockdown, it was down, but we're still seeing a lot. Telecare nil, 78, but really you can't do much on telecare for diabetic foot care if you've got an ulcer. Home visits, we do, and we had a huge number of home visits. Our podiatrists went out to visit patients at home. Hospitalization was down. And the changes were not dissimilar in Los Angeles. Of course, they had much more telemedicine. They don't do home domiciliary visits. Let me give you a couple of cases from our report. The first is a patient of mine who was a 73-year-old male, type 2 diabetes, known to have neuropathy and ischemic heart disease. He presented 3 weeks prior to lockdown with extensive ulcer in the interphalangeal joint right hallux. Good pulses, Doppler signals normal, probe to bone was positive. And this is a distension, a sausage shaped, if you like, distension of the toe, and this lesion is probe to bone. Clinically, that's going to be osteomyelitis. But fortunately, he presented about 3 days before the lockdown. So our clinical suspicions were confirmed on this X-ray. You can see gross destruction here and septic arthritis in the IP joint here. So he was treated with clindamycin ciprofloxacin for 8 weeks, and it healed up completely. And I was able to do an X-ray about 2 months later when they sort of relaxed some of the very severe restrictions. That'd be about 6 months after the COVID pandemic began. We showed radiologic healing. Here's another one of mine, again from Manchester. He presented in week 1 of lockdown, the grossly swollen second toe. Again, pulse is absent, Doppler signal, monophasic, posterior tibial was okay, and dorsalis pedis was not. Positive probe to bone test and sausage-shaped toe. And here it is. I think you would agree this is a sausage-shaped distension of the toe. And the ulcer, you can see here, it probes straight through. He was treated in a similar manner, and we were able to heal that up as well and show radiologic healing. I'm not going to show David's cases because he had some very interesting cases too, but they were mainly surgical. So I'm going to leave you at the end of this talk with 1 or 2 thoughts. And Professor Lindsay, you've heard me use this before, was Professor of Medicine at the University of Belfast about 100 years ago. He wrote and taught his medical students to learn these aphorisms. For 1 mistake made for not knowing, 10 mistakes are made for not looking. Always look at the feet of people with diabetes whenever you see them with shoes and socks removed. So I'm not going to go on to that. I'm going to stick to this. And the multidisciplinary team is important. Diabetic foot care. And this is in order of alphabet, not of importance. And the multidisciplinary team might contain these individuals. Some may include physical medicine, psychologists, etc. But I think the key people here are the patient, of course, the podiatrist, and the pedorthist or orthotist. Shoes are a major cause of diabetes in Western countries. The primary care physician needs to know what they're looking for and when to refer. The diabetologist may be the least important, interventional radiologist, and good good clinical musculoskeletal radiologists as well, diabetes nurse educators, and so on. So what's the success? What's the necessary qualities needed for success? And I would suggest to you, from my experience, that first of all, having good organizational skills is very important in doing research. Secondly, is listening, not only to your patients, but also to your team, to your trainees who may have come up with a very bright idea, to your other members of the team. A bit like communism, all people are equal. I won't say that some are more equal than others, but all people are equal in my team. We listen. So if the podiatrist is worried about something, we listen. Diplomacy, that's very important. We're not seeing too much of that at the moment where I am now. There's nothing on the TV apart from the big election coming up, which the result of which will be known when you listen to me today. There's nothing else on the TV. So diplomacy is lacking there, but diplomacy is very important. Team building, building up a team of people who are reliable and well organized. Patience, nothing occurs overnight. And then prioritization, get your priorities right. And a willingness to collaborate, ability to delegate. Some people like to be a sort of a master of all trades, and want to be in charge of everything. But no, you can't do that. Be willing to delegate to people who are good in that particular field. And a strong team spirit. Most of all is luck. I mean, if you look at my career, I happened to go to Newcastle, I happened to get interested in neurology, and I happened to go to Sheffield, I happened to meet Don Ward, who had a job coming. It's all chance. I wasn't planning to go into diabetes. I don't know what I was planning to do, to be quite honest. And probably genes help. I mean, there's nobody in my family who is a medic at all. The closest I can get to is my grandfather, who is an undertaker, but we won't talk about that. So genes are very important. And what I probably learned from my father and gained from my father and inherited was how to give a lecture. I've never had any training. And also how to use slides with quotations, which really brings people to focus on something before you move on to the next session. And of course, a lot of good luck and the right genes. You can't do much about either of those. So let's leave you with this Chinese proverb. Superior doctors prevent the disease. Mediocre doctors treat the disease before it is evident. Inferior doctors treat the full-blown disease. Sadly, all too common, we're working as inferior doctors. But screening for complications, screening for foot problems, screening for early changes to prevent the evidence also to occur is very important. But if you can prevent the disease, there are now chances to prevent diabetes, as we know from modern lectures and papers recently. And this is an important saying by Edward Wilson: you teach me and I forget. You show me and I remember. You involve me and I understand. So the important thing, because we know that if you educate patients with a very severe neuropathy with a history of ulcers, that's not enough. They need to be involved in their care, and smart technologies making this possible. So let's hope that is useful. And one of Gandhi's favorite quotations was, "He who strives never perishes." So keep striving, keep going, and get to the end if you can. So with that, I will thank you very much for your attention. I hope you have a very good meeting, and I'm sorry I can't be there in person because I'll be in Doha.